who is a pediatric rheumatology consultant at Bristol Children's Hospital. He's also the joint lead for research at the same hospital and of pediatric rheumatology. He has won many awards, and one of these is the British Society of Rheumatology's Innovation in Clinical Practice in 2010, and then the University of Bristol's Vice Chancellor's Health Impact Award in 2017, and then another one in 2018 on the Royal College of Physicians CRN Award for Outstanding Contribution to Research. And he is a great academician, researcher, and has published more than 25 articles. He's a co-editor of many journals, including the Rheumatology and Associate Editor for the Archives of Disease. And he is editor, co-editor of many books, but the main one being the Oxford Textbook of Rheumatology, the 5th edition. So there are many more to his credit, but other thing was he was here in our institute at PGI last month, though I missed meeting him as I wasn't there at that time, but it was a matter of pride for all of us. And so good evening, good afternoon, Ramanan, and it's all yours.
Thank you very much for the kind introduction. I don't know if Dr. Sinha is still around, but there are many parts of his talk which I absolutely loved and couldn't agree more. But there are some where I'm going to take the courage to marginally disagree, but because he told us of what we shouldn't do, but where we are now is what we should do. So what I'm going to do is, much as most of us want to move away from the dreaded era of COVID, there are some important lessons to learn and worth reflecting on those and how it's going to impact our future practice. These are my disclosures. I was part of the Recovery Pediatric Steering Committee, and then a couple of trials, one in India and several nationally, and advisor to Roche and Lilly. So yes, nomenclature is an issue, and most of us in the last day and a half have heard of how using multiple terms which may not really make biological sense can sometimes do more harm than good. But the moral of the story is that there are certain infectious diseases where the greatest morbidity and mortality is not from the infection itself, is from the immune sequelae. And what is it that we can do? Because for long, intensive care and infectious diseases doctors have said supportive care and antimicrobials are the only thing we can do, while the rest of medicine has progressed into targeted therapy. And you've heard a whole afternoon yesterday of multiple terms, and I'm not going to revise that. But you know, even though the term is terribly flawed, and it might be a breeze, it might be a storm, or it might be something even in between those two. But you know that some things really arrived when the New England Journal of Medicine, which till then shied away from this topic, suddenly decides it's worth a review article. And really what we are talking of is a condition, call it what you like, which is seen in the context of what we as rheumatologists have long recognized, what as pediatricians have recognized as hemophagocytic syndrome, and what we have seen in the context of certain infections. And you're going to hear again after me about influenza, and Jan Gehenter has shown even with H1N1 how there was some patients who have done very badly with what was really a hypercytokinemia. The Japanese have long recognized that in some people, EBV can give a really malignant phenotype with significant morbidity and occasionally mortality. We know some lymphomas, particularly anaplastic T-cell lymphomas, will present primarily as hemophagocytic syndrome. And then what is ARDS? And I would always take issue with intensive care. When you go to intensive care, you would always have terms such as ARDS, MODS, multi-organ dysfunction syndrome. In UK, you cannot get a bed in the intensive care unless you have multi-organ dysfunction. So what is MODS, what is SIRS, what is ARDS? And probably a rebuttal, if I may, to Dr. Sinha's previous talk was ARDS is such, as he acknowledged, a biologically heterogeneous entity that a lot of the trials looking at therapies have failed because you're trying to treat an ARDS which may be from multiple etiologies, from multiple pathologies with different. And what this COVID pandemic taught us is at least you have a single virus-induced multiple phenotypes. So it makes life much less complicated. And of course, doing trials was a lot less complicated because of the pandemic nature of this infection. So here's what we understood. We understood you get exposure to the virus, you will have probably a primary pulmonary phenotype. We now know that if you are elderly or if you have antibodies to type 1 interferon, which is a key antiviral cytokine, then you're more predisposed to have significant morbidity and probably mortality as well. We know that there's activation of the alveolar epithelium and activation of the host of the cells, which you have heard repeatedly today and yesterday about monocytes, macrophages, and the pro-inflammatory cytokines. And we know that these are the ones which really predict who's going to do well. We also recognize that the elderly you are, the higher the neutrophil count, the more organs involved, which is intuitive, and coagulopathy. But the coagulopathy is really a reflection of endothelial damage rather than a reflection of a probable procoagulant tendency of the viral infection in itself. Now, you had in the previous talk, multiple people asked the questions, till there is a systems biology or till there is an AI-driven approach, what do we use today? What do we use tomorrow in the pediatric and adult intensive care? If CRP is not reliable, if platelets is not reliable, is there a composite marker which includes CRP, LDH, D-dimer, and platelets, which is where I think Dr. Sinha is going to take us in the future through his website. But Dennis McGonigal and I looked at this early in 2021, and we said, how does the immune cartography of what we as rheumatologists call macrophage activation syndrome, but you can call it by any other name, a hyperinflammatory state is as good for me as any other term. And really, it's worth reflecting that this entity and the huge nomenclature issues exist because there are multiple pathologies which drive this. So primary hemophagocytic syndrome or hemophagocytic syndrome is really an entity that pediatricians, hematologists have long recognized happens in the first few years of life. You have defects in perforin pathways, and you will present with hemophagocytosis in the liver, spleen, marrow. And really, it's the spleen and the liver which are the big organs, and you'll have coagulopathy. We now know gamma interferon is a key cytokine, and we've also identified a host of other cytokines, which such as GM-CSF. But you can also have a cytokine storm in certain infections where you have a capillary leak syndrome, which may present with a phenotype which is very different. Or you may have sepsis with certain infections, maybe bacterial, maybe Leishmania, could well be well-recognized bacteria, which you've given appropriate antimicrobial therapy, and you still see the patient sinking, where it's more multi-organ dysfunction. Or you may have, as in certain infections, and I'll come to later, where it's viral infection of the macrophages with a coagulopathy and a bleeding diathesis, such as in dengue, really. But we now know that the innate and adaptive immune systems both play a role. We can have gain-of-function mutations, which can cause a hypercytokine or a hyperinflammatory state. And we can also have immunodeficient states, such as perforinopathies, which are the mainstay of primary hemophagocytic syndrome. So it's well worth recognizing, while on one hand, you'll have 1-year-old children presenting with pancytopenia, coagulopathy, who turn out to be primary HLH and may need a bone marrow transplant if you can make them live long enough. You can also have gain-of-function mutations, which might be essentially certain autoinflammatory conditions. And of course, the whole term cytokine release syndrome came from CAR T-cell therapies, which have become mainstay in certain malignancies, particularly refractory malignant melanomas. So this is a cartoon trying to demonstrate, on one end, you have clearly loss of function mutations, such as in certain immunodeficiencies, and you have certain conditions which pediatricians might well recognize, which is increasingly being mapped to the appropriate genetic defect, children presenting with an infantile enterocolitis and really a coagulopathy and a pancytopenia, most of whom succumb. Till now, there are going to be targeted cytokine-based therapies. And of course, you can have systemic JIA or Still's disease, lupus presenting with macrophage activation syndrome, EBV and T-cell lymphomas at the other end of the adaptive immune boundary, really. And why is this all important? This isn't so much navel gazing or us trying to show how we understand immunology, but it is more of how we can have an impact at the bedside, really. It's not so much talking about the immune mechanisms, but actually making an impact for the individual patient. And that means moving away from just supportive care to care which targets what might be the key cytokine in these individuals. It might be IL-18 blockade, which is feasible now. Of course, we need to identify the right patient, the right drug at the right time. But we have antibodies to IL-18. We, of course, have antibodies as well as IL-1 receptor antagonists, and we have IL-6 blockade. We have molecules which block GM-CSF. We have a monoclonal for gamma interferon, which is now licensed and approved in the West for primary hemophagocytic syndromes. So there is a huge amount of molecular evidence to target these cytokines if we can identify the right patient at the right time, really. And this is where a lot of these questions come from. So before COVID, when I go to intensive care, I'm generally thought of dispensing medications which cause a lot of harm, such as steroids or IL-1 blockade or IL-6 blockade. Now I'm going to have to hold the hands of my infectious diseases colleagues from giving anakinra and steroids more often than I would. And a lot of that's come about really from the role of dexamethasone in COVID-19, and alludes to the question that Dr. Shetty was asking about the Lancet paper of dexamethasone ARDS. But that's a much more complex study with multiple etiologies. But really, what the recovery trial, which was a landmark when it came out in July 2020, showed that there was a clear improvement in mortality depending on whether you had COVID and you were ventilated, or you had COVID and you required oxygen. But what a lot of people missed was if you had SARS-CoV-2 infection and you didn't need oxygen, you actually had a non-statistical trend to harm with dexamethasone. So a lot of the flack that steroids got was more down to its indiscriminate use and probably not careful analysis of the literature. So if you had COVID and you needed oxygen or beyond, then steroids helped you. But if you didn't need it, then steroids had the potential to be harmful. And most of you would have heard the stories of fungal infection in the context in which you are working in more than I have. And this is to demonstrate that more really this tendency to harm. So if you didn't need oxygen, then usual care was better than usual care plus dexamethasone. And what this has shown was by March 2021, which is just about 9 months after the dexamethasone results, there was estimates that at least 1 million COVID-19 patients' lives were saved by the use of this cheap drug. Now, that isn't a license to go around giving dexamethasone to every patient in intensive care from sepsis, but it is for us to carefully consider whether we need to do similar such trials on large scale to see what the benefit of immunomodulation in settings where the populations are more homogeneous, really. And then let's come to some of the molecules we in rheumatology have long used for conditions such as rheumatoid arthritis and in children with arthritis. Why IL-6, many of you may ask? And I think in the early days of COVID, people thought, okay, some of these patients have high CRP. And incidentally, Dr. Sinha is absolutely right. While high CRP may be reflective of a hyperinflammatory state, I can tell you even before I show this data, because I'm not going to show it, that in all the IL-6 studies in COVID, they couldn't show a clear correlation between high levels of CRP and an improvement with administration of IL-6 antibodies. Of course, in the recovery trial, you had to have a CRP of more than 75 to be eligible to come into the study, but I'll come back. So we know that CRP is a very good surrogate marker of IL-6, and in fact, measuring IL-6 is a waste of time if you can measure CRP. So, and we know that many of the coagulable states that you see in COVID patients could well be explained by the effect of the cytokine on the vascular endothelium, which causes hyperpermeability, increasing tissue pressure and interstitial edema. We know about its role on the C5a receptors. People went on to look at eculizumab, which we know blocks the C5c9 pathway as a means of treating, but we know IL-6 does that for a much in a much more roundabout way, really. And we know about its role on downregulating perforin granzyme activity and the cytotoxic activity, its effects on the monocytes, its effect on the NK cells. So really, IL-6 is what I would describe as a pluripotent cytokine with a vast array of actions across different cellular systems, really. So the first data that came about was really for the intensive care folks. REMAP-CAP was a study which was designed for community-acquired pneumonia and quickly repurposed to look at COVID. And it was an adaptive platform design, which has become very much in vogue now. And what they did was took adults with COVID-19 were within 24 hours of commencing oxygen support in the context of an intensive care unit in adults. And they looked at 2 IL-6 blockers versus just standard of care. And the primary outcome, one of the beauty of COVID studies was the primary outcome was easily understandable. Of course, unless you're an intensivist, you wouldn't understand what a SOFA score is or what a Apache score is. But everybody understands day 28 mortality and days free from organ support, really. So they had approximately 400 patients randomized to IL-6 blockade and 400 to control plus standard of care. And it's clear to see that if you had IL-6 blockade, you had on average 10 organ support free days compared to none for controls. And there was a reduction in hospital mortality. Now, by the time the study was published, lots of these patients had already had dexamethasone. So this was really additive impact on mortality on top of what dexamethasone was offering, really. And IL-6 in the intensive care setting in the REMAP-CAP study reduced mortality by 8.5%, really. And then you had recovery, because we just don't want the critically ill patients, but we want all hospitalized patients who are needing oxygen and beyond. And it was a much larger cohort, really. They took 2,000 patients in the standard of care plus tocilizumab, compared with 2,000 patients in standard of care. And you can see that for every 25 patients you treat with tocilizumab, 1 additional life was saved. So this is not just number needed to treat, but really number needed to save lives. And this is clearly additive, because 80% of these patients had already received dexamethasone. So you're talking of cumulative immunomodulation, something which we wouldn't have even considered. It would have been one or the other. And here we're demonstrating that 80% of the patients who received dexamethasone and then went on to get IL-6 had an additive reduction in mortality. And the greatest impact was on those needing oxygen and mechanical ventilation, and particularly poignant at a time when there was difficulty in accessing ventilators was those who got tocilizumab and were just on oxygen or non-invasive ventilation. The need for invasive ventilation was clearly reduced. So impact on multiple fronts, on not just mortality, but also on access to ventilation. Of course, there is Indian data as well, which Dr. Soyan led across some hospitals, demonstrating the ability to do randomized control trials in India in an acute setting as well, which was pretty similar to the rest. And then I was part of this whole WHO meta-analysis led by my colleague in Bristol, Jonathan Stern, and really it looked at almost 11,000 patients from 27 trials and showed that IL-6 blockade was clearly reduced with a reduced 28-day mortality. So the message was clear and led to WHO and multiple countries approving this medication for management of adults. Now, a molecule which I'm more closely involved with, although I did lead a couple of studies of tocilizumab, was baricitinib. Now, here's a molecule which is really the face of this decade of adult and pediatric rheumatology, because these are small molecules, oral, but have the same level of biological efficacy as our injectable monoclonal antibodies to IL-6 and TNF. And early on, Justin Stebbing from Imperial in February 2020 suggested using an AI platform that baricitinib was one of 4 molecules which might help in COVID. Now, this is a month after the pandemic really came to the attention of the world after the outbreak in Wuhan. And he speculated, by now baricitinib is licensed and approved for rheumatoid arthritis across multiple countries, including UK. So we knew all about its anti-cytokine effects. We knew about the role it has in blocking IL-6, blocking GM-CSF, which we thought were pivotal pathways in its efficacy in rheumatoid and other inflammatory conditions. But this speculation that it might have an antiviral effect by acting on NUM kinases was really strange, because one of the side effects of baricitinib in its rheumatological indication was reactivation of herpes, or herpes zoster, really. So then to have somebody speculate that short courses may actually be antiviral was very counterintuitive. So along with Vincent Marconi and Vesely, we led this large almost 1,700 patient randomized control trial across Europe, North America, Latin America, and parts of Asia, including India. So One of the novelties of our approach compared to recovery was we actually did a placebo-controlled trial. Recovery was mainly standard of care after randomization. So everybody knew who got the drug and who didn't get the drug, while the standard of care being the same. So here we went for a placebo versus the active drug. So you got baricitinib once a day plus standard of care, or equivalent placebo once a day plus standard of care. And baricitinib being a small molecule is a tablet really. So we had very strict inclusion criteria. You had to be about 18 years, hospitalized with lab-confirmed SARS-CoV-2. And then the question which has been asked in the last talk and in the previous talks yesterday was, we came up with a mishmash of clinically relevant, because we didn't have the benefit of doing biomarkers which are not universally accessible or AI machine learning driven tools. So we said a mixture of CRP, D-dimer, LDH, and ferritin, you must have elevation of at least one of these inflammatory markers. And of course, you must have saturations less than 94, evidence of active COVID infection, requirement for supplemental oxygen, and radiographic infiltrates on plain radiographs or more sophisticated imaging. We excluded those who needed mechanical ventilation or ECMO because we thought an oral drug isn't going to be that efficacious in this critically unwell cohort. And then went with certain exclusions, which are part of the product features from its rheumatological indications, really. And what I'm demonstrating here is baricitinib clearly reduced mortality when compared with placebo. And if you compare it with those who needed oxygen at baseline and not receiving systemic steroids, then it was much more. Again, a bit like the tocilizumab study, 80% of the patients were on steroids, but those 20% where the sample is smaller weren't on steroids. The effect of baricitinib was much more pronounced. But in the overall cohort, which includes 80% with dexamethasone, there was still a statistically significant reduction in 28-day mortality. Now, parts of the world used remdesivir, mainly North America. So in the small population which used remdesivir, again, we showed that there was no major difference. But if you didn't use remdesivir, you can see there was a clearly statistical significant difference. And this is showing the gap between using steroids and not using steroids. So the reduction in mortality was more pronounced if you didn't have steroids, but equally significant even if you had dexamethasone, which the vast majority of these patients had. Now, one of the major risks, apart from viral infections in baricitinib use in the adult rheumatology population, was also that you had a thromboembolic risk. In fact, there's a current FDA label alert saying if you are taking baricitinib for rheumatoid, be aware of major adverse cardiovascular events or of thromboembolic manifestations. But what we showed here was a 14-day course in an infectious disease-driven hyperinflammatory state. There was no risk because the thromboembolic manifestation risk that was seen with COVID was really driven by the inflammatory state rather than any others. And bringing down the inflammatory cascade is more likely to reduce your chances of thromboembolic manifestations. And what is shown here is that there was no significant difference in either non-serious adverse events or serious adverse events. The FDA then asked us to do a study on those who are ventilated and those who are needing ECMO. So we went on to do another 100-patient randomized controlled trial. These were all invasive mechanical ventilated patients or needing ECMO, and 50 of them were randomized to baricitinib. Another 50 were randomized to placebo plus standard of care. And to our surprise, again, in this very severely ill ventilated or ECMO cohort, baricitinib significantly reduced all-cause mortality. So mortality was less than 40% in the baricitinib group compared to almost 60% in the placebo group, which is a significant risk reduction of almost 20% with baricitinib in this critically unwell group from COVID. And it wasn't just day 28 mortality, because one of the critiques or criticisms of day 28 is what if they die on day 35? It's too short a time. So we went on to look at day 60 mortality. And again, you see an absolute risk reduction of almost 17% with baricitinib treatment in this mechanically ventilated or ECMO population with COVID-19, showing that this oral drug, even when given by an NG tube for 14 days, has a clear and demonstrable reduction in mortality. The key messages from this study, these two studies really was baricitinib patients showed not only reduced mortality, but numerically more ventilator-free days, so organ support-free days, spent few days less in the hospital than placebo. And most importantly, the risk of secondary bacterial infections, which is always a cause for concern in adults in the intensive care, or thromboembolic manifestations, or major adverse cardiovascular events, which are label warnings of baricitinib, were very similar between the two treatment arms. So short courses of baricitinib clearly proving very helpful. Now, these were reasonably large studies, but not as large as recovery has the potential to do. So recovery then looked at 8,000 patients. And what is interesting, and I'll come to that in a minute, was 4,000 to baricitinib plus standard of care and 4,000 to just standard of care. And again, they demonstrated that these patients had a reduction in mortality. Now, 20% of these, almost 95% of these patients had had dexamethasone, and about 20% of these patients had also had tocilizumab. So you're having additive immunomodulation on top of steroids for about 95% or almost all, and additive immunomodulation on top of dexamethasone and tocilizumab for about 20% of the patients. So 1 in 5 patients are having a 3-drug immunomodulation regimen with dexamethasone, tocilizumab, and baricitinib. And in spite of that, you're getting reduction. So you would have thought if immunomodulation could only be impacted by one drug, you would have thought that tocilizumab addition wouldn't have had an impact, or baricitinib on top of tocilizumab wouldn't have had an impact. And what we found was not only it was proving efficacious, but it was also relatively safe. Of course, recovery being the third immunomodulatory agent in some, and in second in all of them, the meta-analysis shows the survival benefits are much reduced when you compare it with recovery than without recovery. So again, of these 8,000 patients, 95% were on steroids, and I would say almost 1 in 4, not even 1 in 5 were on tocilizumab. And there was a clear statistically significant reduction in mortality. And you can see if you exclude recovery, the meta-analysis shows a 43% reduction in mortality with baricitinib, with the recovery data which included 1 in 4 patients being treated with tocilizumab, you have a 20% reduction in mortality. Both of these are certainly what most intensivists would clearly embrace for any interventional regimen. Not to forget anakinra, about which you have heard a lot. There was only one investigator-initiated study. And what was novel about this was they used a biomarker to decide who gets anakinra and who doesn't, really, which is what the previous speaker was alluding to, that with the biological heterogeneity of ARDS, you really need to target your patients or who's going to benefit. And here they used serum urokinase plasminogen receptor levels to decide who gets anakinra. And again, they showed that at day 14, you have a reduction in mortality in the group which got anakinra compared to group which got placebo. And this was seen at day 28 as well in terms of reduction in mortality. So anakinra also is useful. And now where we are, not just in 2022, 2023, is the WHO currently recommends only 3 drugs if you are unfortunate enough to get COVID, and that is dexamethasone and tocilizumab or baricitinib. Hopefully, we wouldn't have to face this scenario of a resurgence, but if we do, my vote would be for baricitinib over tocilizumab, because the half-life of baricitinib is 12 hours, and you can stop if you run into problems with either secondary bacterial infections or fungal infections. On the contrary, with tocilizumab, once you've given 8 per kilo, you have a half-life of about 6 to 8 weeks, so you really have no possibility of reversing should you run into problems with secondary bacterial infections. But the point I'm saying is we have moved so much that we've moved in this viral infection in 2 years from just supportive care to now having 3 immunomodulatory drugs, something we don't do for any other viral infection patient who comes in unwell or is critically ill. Now, most of us are facing a much more serious problem, and many would argue that there were more deaths to children even during the height of COVID from dengue than from COVID itself. And really, it's not a problem for the Western world unless global warming makes it a problem with mosquitoes happening in Europe as well. But I feel it's much ignored. There are very few randomized controlled trials. There's significant paucity of data. Now, I don't need to tell any of the assembled audience about the issues with severe dengue, but enough to say that you have a small proportion of patients who can have all of these problems from shock, dengue shock syndrome, or the thrombocytopenia, the coagulopathy, and the significant organ impairment that you can see. And I highlight to Priyankar Pal's work in one outbreak where they looked for cheap and simple biomarkers such as ferritin and full blood count, and gave steroids. I know that runs counter to the WHO advice, but had no mortality in that. Now, that was a cheap and cheerful study. Now, why would we think that dengue patients may have a hemophagocytic syndrome-like picture? And what I'm showing you here is this is familial hemophagocytic syndrome and the genes which are overexpressed. This is patients with systemic JIA and genes overexpressed. This is EBV-induced HLH, Yersinia, and what you see is significant homology in the genes which are overexpressed in dengue-associated hemorrhagic syndrome and the familial hemophagocytic syndrome. So it's no surprise that the tiny proportion of dengue patients who get critically unwell may have a form of hemophagocytic syndrome, or call it what you like, but really an hyperinflammatory state. And this is clearly correlated with the levels of ferritin and viremia in this one study. No doubt that this is retrospective, but it just clearly shows that the viral load in some dengue patients is associated with hyperferritinemia, immune activation, and a coagulopathy picture. Now, Yaning Inter shows this nice work from Malaysia where he looks at dengue infection complicated by what he calls as a hemophagocytic syndrome, looking at 180 adult patients with severe dengue. And I just want to focus on the highlighted bit. So it's a total sample size of 180 patients. And he looks at the survivors versus non-survivors. So if you look at the peak ferritin in the survivors, it's 20,000. Most of us would agree that's significantly high. But look at the ferritin in the non-survivors, 72,000. And the same with LDH, 800s in the survivors, in the 6,000s in the non-survivors, and more renal impairment and renal failure in the group, which sadly did not make it really. And this made Sophie Yacoub and us to really speculate. We have this hyperinflammatory phenotype in infections. We've certainly recognized it in COVID. We may not have a biomarker, but we've made significant therapeutic advances till the vaccines became available for us to fight the pandemic. But why can't we harness all of this therapeutic momentum and do something which affects really low and middle income countries? And this hyperferritinemia and immune activation I've already demonstrated to you in the previous slides is associated with not just ferritin levels, but also with the thrombin levels and the ICAM1. And Randy, who's in this call, we speculated long before this pandemic about how certain viral hemorrhagic fevers might really reflect a form of hyperinflammatory state. And again, there may be a window to intervene, and I am no dengue expert, but I certainly think that there is a window of opportunity for those of you who see a lot to do the appropriate randomized control trials, either with placebo or certainly with randomization, to see if there is a phase where you can immunomodulate to prevent the progression of these patients to multiple organ failure and morbidity and sadly in some mortality really. Now we are doing this, Sophie is leading a study which I'm part of, looking at anakinra for dengue patients, both adults and older children with hyperinflammation. It's going to be a randomized double-blind placebo-controlled trial. And the hypothesis really being that IL-1 mediated pathways drive hyperinflammation, and there will be a host of associated immunological and transcriptomic analysis really for experimental pathways. But many of you may ask, if you're an intensivist, I used to be asked periodically, you're coming in and giving a cytokine blocker, what's that going to do? And I think I want to highlight to you is that this paper, which was published in the 90s, was looking at the role of IL-1 receptor antagonist anakinra in the treatment of patients with sepsis. Now, that paper didn't show a statistically significant result for efficacy, but it showed a trend towards these patients doing better until Beta Shakuri and others did a reanalysis. And what they did when they looked at the reanalysis of this original late 80s, early 90s phase 3 data was showed that you could divide them into two groups, really what we recognize as hyperinflammatory group or not, which they call as hepatobiliary dysfunction plus DIC versus just hepatobiliary dysfunction or DIC or not having either. And the simple moral of the story was that day 28 survival was much better in the group which had hepatobiliary dysfunction and DIC, suggesting that giving all comers a drug may not work, but giving targeted to certain patients. Now, one of the problems in a lot of the sepsis studies, a lot of the hyperinflammatory studies, and a lot of the ARDS studies, you're trying to give one approach for a condition which comes from multiple etiologies, and you don't even know what one person calls as ARDS is what another person calls as an ARDS or a sepsis syndrome, really. And this is again Joe Carcillo's data, which I think was briefly shown yesterday, but I'm just showing you one data which really suggests that if you have multi-organ failure and you have sepsis and you're going to die, really the group which dies as an MAS phenotype or a macrophage activation phenotype or a hyperinflammatory phenotype. The moral of the story being that the patients with sepsis who die may not die because of the infection, but it's because of the immune activation and the inflammatory cascade from the immune activation, which contributes, if not leads to their death, really. So the key message is that if we want to learn from COVID, that infections, viral, bacterial, parasitic, in a small proportion does cause a hyperinflammatory state. And we need to carefully consider whether immunomodulatory therapies would benefit these patients. And for certain conditions like dengue, the evidence base has probably got to come from countries such as India, where we need to organize large randomized control trials to provide the same sort of evidence base that we've managed to achieve in 2 years with COVID. Thank you very much.
Thank you, Dr. Ramanan. It was really a wonderful talk and a lot of work which you have done. So it's really commendable. But that's important work which you have done and may have changed the practice in many of the centers and saved many lives. So moving forward, just wanted to ask you a few queries on these questions. Like most of the work which has been done on either tocilizumab or baricitinib is on viral infections mainly. So when in practice, it becomes really difficult to distinguish between the initial infection, whether it's bacterial or viral. And most of the time, the workup is also negative. So what do you suggest in those cases?
Challenging question. I think, you know, in most of us in our clinical setting, in the first 24, 48 hours, would always give appropriate antimicrobial therapy. We had a case yesterday where we give antiviral, and depending on the setting you work, even antifungal. But after a while, we may need to become agnostic to what the infection is and look at whether there is immune activation. And if we are comfortable that we have managed the underlying infections, we've looked appropriately for the etiology, it might be then worth considering if this patient has a hyperinflammatory phenotype. And of course, you've heard a lot about people wanting to come up with better biomarkers. And we welcome that. But till they do that, today, tomorrow, and the day after, you're going to have patients in your intensive care where you'll have to make this call. And we may have to do with much more rudimentary tools. Yes, CRP is not the be all and end all. Yes, LDH is not everything, but it may be a mixture of ferritin, CRP, D-dimer, careful clinical judgment, and deciding who would benefit from immunoglobulin depending on cost considerations and when we can use steroids. But really, the biggest thing I'd say is for the need for trials. And in these trials, we may need to be carefully stratifying. One of the reasons a lot of the intensive care trials to me may have shown equivocal results is because you're clubbing multiple pathology patients into one study, and that might result. So I suspect having something similar to what we did in the Barry trial, a mixture model of needing to have 2 or 4 inflammatory markers elevated before you choose to go in with immunomodulation.
Yeah, I think that makes sense. In the same line that you said that you first rule out, treat bacterial infection, rule out the different etiologies. So means at what stage based on your trials, we should be starting these drugs? Means any markers which are there or any days based on that you add these immunomodulatory therapies to your antimicrobials?
Again, in the trials were very different because they were done in this context of a single viral infection and life was easy. But the question you're asking is when you don't know what's wrong.
Yes.
And I generally, in my own close interactions with intensive care, rarely do anything in a rush in the first 48 hours unless, you know, they are at death's door. So we usually want to be reasonably satisfied that we've given 24 to 48 hours of appropriate antimicrobial therapy. Now, the infectious diseases guys will tell you that most sepsis, at least bacterial sepsis, one dose of the antibiotic substantially kills 90, if not 99% of the bacteria. So once you've given 24, 48 hours of what you think is an appropriate antimicrobial therapy, you can start looking at immunomodulatory. And then it comes what really? Of course, immunoglobulin offers you the advantage of not interfering with disease process, being more comfortable in a setting where you think there is still significant septicemia, whereas steroids brings with it more concern, although we are becoming more and more comfortable that steroids were not as bad in infections as they were thought to be. How beneficial they are remains to be seen. And other therapies such as anakinra, again, I know is an access issue, so I don't want to talk too much about it, what we do with it, because for us, it's more like IVIG because we are satisfied it's safe in sepsis. So we are able to use it early on, even before steroids, if we are very concerned about the role of steroids in sepsis. But I know that access to anakinra is almost
very limited here.
Yeah, very limited. And so for which I'm very conscious of not talking it up too much.
Yeah. Another interesting thing which you raised up was the cumulative effect of immunomodulation, that you found that it is better than individual in few of your papers. So do you suggest that when you start, we start steroid and other drug together, or we hike it up stepwise?
Oh, Dr. Bansal, you're asking all the most difficult questions, really. So I was more wanting to say that there is the conventional wisdom is we were for long not wanting to use immunomodulatory therapies, which for some reason people would refer to as immunosuppressive therapies. And I think that sends the wrong connotation. But I was more alluding to the fact that these two therapies in the tocilizumab studies were proving efficacious and not anymore. The safety wasn't that worrying. And in the recovery Barry trials, 1 in 4 had 3 drugs. So I wouldn't rush to go straight for cumulative immunomodulation. I would do it much more serially and vary for each patient. But I think the safety of 2-drug immunomodulation in COVID adults and the safety of 3-drug immunomodulation in COVID adults is very reassuring that that might be the way forward in some. And also because the dexamethasone doses used are different. Now, of course, there is some talk that what if you use super high doses of dexamethasone, you might exclude the need for drugs such as anakinra or tocilizumab, which are much more expensive. Baricitinib has the advantage of being a small molecule and in time becoming incredibly cheap. Even during the pandemic, I think in India, it was very cheap for a 14-day course. And I think for me, the small molecules is where we must be looking at trials in conditions such as dengue with JAK kinase inhibitors such as baricitinib or tofacitinib, because they are cheap, 14-day course, short half-life, ability to reverse the immunomodulation should you need to in the context of secondary infections.
Yeah, thank you. Another thing is in recent last few months in India, we are facing a lot of surge of respiratory viral respiratory infections. So many children are coming with either RSV, human metapneumovirus, H3N2, even ICMR has issued an advisory. Even in PGI, in our emergency in last 2.5 months, we had seen almost 500 kids with pneumonia alone. With viral infections, many of them with proven viral infections, and many have died. So do you think that these kind of therapy, if they have this hyperinflammation, will work in these viral infections, like you touched dengue?
I do, and in fact, we've on a very small scale in the southwest of England and parts of England have had an enterovirus-related severe myocarditis, which was small anecdotes, small observational series who had catastrophic outcomes until we started using anakinra. Of course, we couldn't persuade our infectious diseases colleagues and intensivists to do steroids, but we used a combination of IVIG and anakinra. Observational, anecdotal, we've reduced the mortality. So I think there is a role, better done in the context of, I always hasten to add, better done in the context of a trial, because otherwise universal adoption of these therapies becomes hard. So I would urge you, I think, yes, the short answer is yes, there's a role for immunomodulation, better done within the auspices of a trial in big institutes like yours.
We have couple of questions in the chat box before we move forward. Hand it over. You have time, 2 minutes more?
Yeah, I have. Thank
Okay.
you. Yes.
So
should I read
there
them
are
out?
two from Mahesh, one Mahesh Kori and then Mahesh Mohite. One is about, what about tofacitinib?
Yeah, we look, if you have difficulty in accessing baricitinib, it's perfectly reasonable to use tofacitinib, but the data is all with baricitinib. Now, baricitinib is a JAK1/2 inhibitor, tofacitinib is a JAK1/2/3. There'll be small considerations, but if you extrapolate from adult rheumatoid literature, they're not vastly different. They're selective rather than being specific for those subtypes. So I know tofa is very easily accessible in India. So I think it can't be too bad. There was one study which showed some efficacy with it. So I think you won't go wrong with using it.
Okay. We don't have the name of this person who put it up. He said, any difference between DEX versus methylpred in hyperferritinemic sepsis, ARDS?
Not much really. DEX has always been preferred by certain groups because it has better CNS penetration. The rheumatology folks always preferred methylpred, but I don't think that's splitting hairs. Either of those, if you're comfortable with the bigger concern is not to be so worried about the use of steroids rather than, but I think someone wants to answer the question, Dr. Gupta, maybe he might shed more light.
Okay. And then maybe last one is, he's asking that in a country like ours in India, doing an RCT using steroid against IL blockers may be more beneficial. What do you think? I think that you have already answered that we need some trials from India, and there's the best place where we can do.
I wouldn't do steroid versus IL-1. I would do steroids versus, I would do standard of care versus a JAK kinase inhibitor or standard of care versus steroids, because IL-1 is always going to be very expensive and unaffordable in the context because there are not many, there's only one company making it. Whereas tofacitinib, as you know, is extremely cheap, and baricitinib during the pandemic was made available for about 500 rupees for 14 days. So that's where we should go.
Okay. And maybe I'll leave 1 or 2 questions for you if you can answer them in the Q&A box so we can move forward for the other talks. So thank you so much, Dr. Ramanan. It was really a pleasure interacting with you. Thank you so much.
Thank you.
Thank you, Ram and Dr. Bansal, for that session. I now request Dr. Tanu Singhal to introduce Dr. Karthik Narayan for the next talk. Over to you, ma'am.
Hello, can you hear me?
Yes, we can.
Yeah. So thank you so much for inviting me. I now want to invite Dr. Karthik. He's a consultant in pediatric intensive care at Rainbow Hospital, Chennai. He has trained in pediatrics and pediatric intensive care at PGI Chandigarh. And he has been a speaker at various forums, and he has a lot of publications to his credit. He's now going to talk to us about influenza in children. Over to you, Dr. Karthik.
Thank you, madam. My screen is visible?
Yes, it is.
Yeah. So good evening, everyone. So that was an exhaustive and like it was a very complete talk by Dr. Ramanan, and I think most of these things have been discussed for the past 1.5 days of this session. So now influenza, is this topic relevant today? Yes, I hope, because these are the recent news that we are seeing right from various parts of India in the past few hours. We are getting a rise in influenza-like illness, as we all know. So in this talk, I'm going to brush about the extrapulmonary effects of influenza, and is the flu a prototype to COVID-19, and how it is different and what is the evidence that is available. and what are the pathophysiology of these manifestations and the prevalence, and how to identify these extrapulmonary manifestations. So extrapulmonary manifestation in influenza can be both infectious as well as post-infectious. So mostly these post-infectious manifestations, they happen a week after the viremia phase disappears, and whatever might be these manifestations, it could be in various organ systems like cardiac, neurological, musculoskeletal, hepatic, hematological, as well as endocrine. So this is in short a Lancet review which summarizes the various manifestations of influenza. Like it can cause myocarditis, pericarditis. In adults, it can even lead to myocardial infarction. Gastrointestinal manifestation, hepatitis is very rare, but still can occur at sometimes. Pancreatitis and severe acute abdomen-like pain. Myositis is commonly seen in children. Influenza-associated myositis is very well known. And acute kidney injury can occur when there is a severe ARDS due to influenza. Encephalopathy is a very common manifestation in influenza, that extra pulmonary manifestation that we see. And co-infections, that is very common, and nowadays we see a lot of children with viral pneumonia coming with a secondary bacterial infection. So any pneumonia can have a co-infection with either a bacteria or another virus associated with it. And there are these influenza can also exaggerate an underlying chronic comorbid conditions. So they cause these by two mechanisms. One is by direct viral tropism, meaning the influenza virus directly invades the particular organ system, or due to systemic inflammatory effect, where the inflammation in one organ gets spilled over and leads to a systemic inflammation, and that is causing the effect in other organ systems. So this is what happens. This in the left side is influenza and the right side is coronavirus. Almost the initial progress, apart from the receptors in which it activates, it's almost similar. Like both these organisms, they activate the pathogen recognizing receptors, which in turn activates the nuclear factor kappa beta and stimulates the release of TNF and interferons. And that will cause further activation of the cytotoxic T cells and macrophages, further releasing more cytokines and chemokines, and causing the other neutrophils and macrophages and dendritic cells to come into the alveolar space and triggering an inflammatory response. So that causes a local inflammatory response. But when this cytokines and chemokines are spilled into the blood, it leads to endotheliopathy, and this will lead to breakdown of endothelial glycocalyx, exposure of heparin sulfate and p-selectin, and leading to an activation of complement, activation of coagulation pathway, and further this activates the inflammation, and that will further increase the cytokines and chemokines in blood. And this will lead to there are many terminologies, whether it is a cytokine wind or a cytokine storm. It goes into a vicious cycle unless we stop the vicious cycle, or the viremia comes down and the body itself acts with an anti-inflammatory response. But if it is not coming under control, it goes out of control, it leads to a cytokine storm. So when you compare both influenza and COVID-19, you can see the cytokine profile of SARS-CoV-2 is more broader as compared to the cytokine profile that we see with influenza. But even though the pro-inflammatory cytokines like TNF, interferons, IL-8 are very common, and the anti-inflammatory of IL-10 is also associated with both, SARS-CoV-2 has a broader profile with both Th1, Th2, and Th17 related activation. So both these viruses, they don't have a similar cytokine profile, and therefore the method of immunomodulation in both these viruses might not be the same, but we don't have the evidence till date. As Dr. Ramanan said, we need to do further studies in order to elaborate on further how to manage these cytokines. And this is one multicentric study which is done in children to identify what is the kind of cytokine profiling that we see in children with influenza. And this is it is in these children, they are correlated with these cytokine profiling along with the severity of influenza infection, like along with shock, ALI, ARDS, and children requiring ECMO or children who died. And what they found is these children, they had an elevated expression of IL-6, IL-8, GCSF, and MCP1. And this is a BAL lavage. Like previously it was discussed in Dr. Pratik's talk, that the BAL might not offer more information for a hyperinflammatory phenotype as what has happened in the serum, and they found exactly that. They found that the ball didn't offer much of a response to distinguish the cytokine elevation as compared to what they saw in the serum. So therefore, there is definite systemic inflammation in influenza, which is associated with severity, and most of these pro-inflammatory cytokines, they are higher when it comes to influenza or severe influenza, leading to mortality or very high morbidity. So what happens in influenza? So whether it is the viral tropism or whether it is the inflammation. So in COVID, we all know that if you see the viral proteins or the viral receptors of ACE is spread over multiple organs. So the virus also goes to various organs and elicits local inflammatory response. Again, this inflammatory response can spill over, leading to that particular organ failure. Whereas in influenza, the primary tropism of the influenza virus is only respiratory tract. So anything which is spilling out of the respiratory tract might be because of a systemic inflammation and very less likely due to the viral tropism. So what people have found in various studies is various animal models, it's not human models. In various animal models, whenever there is a severe influenza infection that is causing an effect on other organ system, the local cytokines, they are elevated. Like in the CNS, when there is encephalopathy and seizures, there is microglial activation along with increased IL-6, TNF-alpha, interferons, and decreased neurotropic factors. So everywhere there is a localized elevation of cytokines, but the viral tropism is not too great, but the inflammation is more, which is causing the problem in these areas. So in many, there are studies which identified specific extra pulmonary manifestation. One study is done in PGI. So here they studied few cases of influenza, which presented with neurological manifestation in the acute phase. And all these neurological manifestations were seen. In their study, the overall prevalence is around 8%. But overall, in the various studies that has been done from Asian countries as well as in in Australia and other parts of West, the prevalence ranged from 7.6% to 33%. So most of these inflammation-related neurological injury can be termed as influenza-associated encephalopathy, acute necrotizing encephalitis, for which there was a talk before, hemorrhagic shock and encephalopathy syndrome, mild encephalopathy. These are all radiological diagnoses. And nowadays we are seeing more of acute encephalopathy with seizures with late diffusion restriction and encephalopathy with malignant brain edema. So what is new in this? These are encephalopathies which are in the acute phase caused by a localized inflammatory reaction in the brain. So this is not due to the viral tropism. And most of these, when you do a CSF analysis, you don't get H1N1 or H3N2 to be positive. When it comes to the liver has multiple modes in any viral infection to cause a liver injury. SIRS is obviously one of the reasons, and cytokine release. Ischemic injury in any viral ARDS, when there is hypoxia or when there is shock or ischemia, that can lead to ischemic liver injury. Direct hepatotoxicity, which happens in corona, and drug-induced liver injury, those drugs that we give it to the patient. But direct hepatotoxicity is not demonstrated in influenza, but in influenza, what we know is when there is an underlying mitochondrial cytopathy that can induce a liver failure. And therefore, in influenza, it is either the systemic cytokine release or mitochondrial cytopathies which can induce a liver failure, even though the liver failure incidence in influenza is very minimal. But hepatitis is there in influenza. This is one study which is done in Germany, where they have observed around 922 patients with acute viral infections, and they found that influenza B has the most common elevation of transaminitis, but not liver failure. The transaminases was elevated 3 times more than the normal range, followed by human metapneumovirus, and then followed by the coronavirus. So hepatitis can happen, suggesting that there is a systemic spillover of inflammation, but it is not too severe to cause a hepatic failure. Now coming into the heart, we are all worried about myocarditis. Again, in influenza, myocarditis incidence is less than 5%. But whether this myocarditis is due to the viral tropism or inflammation, that is the question, because we need to know what to target. So here there was a study done in Spain in mouse models, where they had 2 viruses. One is the pathogenic influenza virus, and the other is an attenuated influenza virus. And the mice was bred, the attenuated was kept in controls, and the pathogenic was in the cases. And what they found is that the viral load which is in the heart has no relation with the viral load in the lungs. The viral load is much, much lesser in the heart. But in the pathogenic virus, the inflammation which is produced in the heart is much, much more. There is an early increase in inflammatory cytokines in a pathogenic influenza virus as compared to an attenuated virus. And therefore, it is the inflammation along with the minimal viral invasion which is causing the problem. And therefore, even in myocarditis, we find that inflammation is leading to a significant damage. So having known these, should we target the cytokines in influenza with immunosuppression like we did in COVID, which was a crux of the previous talk by Dr. A.V. Ramanan? Should we do that? Because in influenza studies, we didn't do that. So what we saw during the influenza pandemic, we saw a child, like for example, this case, a 2-year, 9-month-old child with fever and cough and cold for initial 5 to 7 days with breathing difficulty for 3 days, coming with lethargy and depressed sensorium. Child is in shock in our ER. We did all possible. There is rapid deterioration in spite of antibiotics, and then child expires in few hours. If the child gives, we have time to give antibiotic, we have time to resuscitate. But if there is a rapid deterioration, rapid sequential multi-organ failure, that is when what we should do. So in this child, we had blood culture to be positive for pneumonia and the swab was positive for H1N1. So what exactly is happening here? When you see the labs, there was pancytopenia, there was elevated ferritin, there was elevated LDH and elevated CRP. But this child also had a secondary bacterial pneumonia or secondary pneumococcal infection. So here you found there is a significant leukopenia. So either this child would have been, this early death could have happened in the initial 2 days of fever, but our death happened on 7 days to 10 days along with the secondary infection. So probably our child is in the immunosuppression phase, and the late deaths are due to persistent immunosuppression which has happened. So again, the window is very short. So if you have to use immunosuppression in extrapulmonary manifestations of influenza, you need to use in the phase where there is the cytokine storm, because this phase rapidly shifts to the phase of immunoparalysis, leading to a secondary bacterial pneumonia. In the H1N1 previous pandemic, the secondary bacterial infections due to pneumococcal and staphylococcus has caused an increased risk of mortality in most of these patients. So we have to identify this particular window if we have to target, or we need to prevent the secondary bacterial infection, and we need to identify when there is a small change, we need to hit hard with antimicrobials. So still there is a lot of debate on when to use, what is the underlying immunopathology, and how to diagnose this underlying immunopathology, whether IL-6, CRP, and ferritin. With these 3 biomarkers, is it sufficient for us to diagnose whether this child is in the phase of cytokine storm or the child is past the phase of cytokine storm? And when to treat, how to choose the patient, the disease severity in influenza, when to initiate, whether it is before the mechanical ventilation or after mechanical ventilation, or when there is a sequential organ failure, and what is the appropriate immunosuppressive drug. So all these are still not yet clear in extrapulmonary manifestations of influenza. But what we know that hypercytokinemia is associated with poor prognosis. Increased CRP levels in influenza is associated with poor prognosis. Hyperferritinemia is associated with poor prognosis. And again, markers of immunosuppression like lymphopenia, reduction of NK cell counts, and reduction of CD4 and CD8 T cell counts are associated with poor prognosis. So eventually, whether it is immunoparalysis or sequential multi-organ failure, it all leads to macrophage activation syndrome or something like that. So whatever we are looking into, or when we should initiate our therapy, whether it is too late or no, but until we find that there is a hyperferritinemia, there is a hepatobiliary dysfunction, and there is DIC. These 3 are very important features. There should be elevated ferritin, there should be a hepatobiliary dysfunction, and there should be a DIC, and you should give a sufficient antibiotic cover. So when you have all these 3 things, then it means that your child has an immune dysregulation and your child requires an immune modulation. So what are the immune modulation that has been attempted till date, and what can be attempted in the future from the lessons learned from COVID-19? So till date, yes, corticosteroids have been used, but still it has been ineffective in decreasing the long-term mortality. But yes, in the time when we are using corticosteroids has been found to decrease the inflammatory effect, but it does not decrease the mortality. But IVIG therapy in 1918 Spanish influenza, where they used blood products, and in 2009, where they used IVIG, they observed a reduction in mortality. So should we institute IVIG in these patients when we identify an immune dysregulation? Or should we plan for extracorporeal therapies? These are still questions under consideration for which trials are needed. So I am ending my talk in the extrapulmonary manifestation of influenza with more questions rather than answer. Immunomodulatory therapy in influenza illness is very limited. We don't have too much of research on that. Who might benefit from the immunomodulatory therapy in severe respiratory viral infections and extrapulmonary infection? We don't know. At what stage we need to use this still needs to be evaluated. Which immunomodulatory drug could be effective for the management of cytokine storm? So is there any specific immunosuppressants, or should we go with steroids? Or we can use immunoglobulin, which has seen at least a partial effect in these patients, which has an observed effect in influenza. And for specific localized extrapulmonary hyperinflammation, which is seen in CNS like ANEC, AACD, and para-infectious autoimmune condition associated with influenza, definite immunomodulation is the key, and IVIG and steroid use have shown effectiveness. And for acute influenza, both pulmonary as well as extrapulmonary antivirals is the key therapy. Thank you.
Thank you, Dr. Karthik, for that very nice session. Just a couple of comments. The first is that, if you look at use of corticosteroids in influenza, I don't think there are any randomized controlled trials. But there are observational studies which actually suggest that the mortality is higher with the use of steroids. Now, of course, there may be a bias that people who are more sick got the steroids. And in fact, if you look at the WHO guideline statement, they say that steroids should not be used routinely in influenza.
Yes.
So that is my first question to you, because though we see the extrapulmonary manifestations, our main concern is children coming in with severe influenza, pneumonia, and ARDS. So what would your thoughts be about use of immunomodulation in these patients, given the fact that we don't have RCT and given the fact that cohort studies show worse outcomes with steroids?
What we usually do is we monitor the organ function scores. If it is a localized severe influenza restricted to the pulmonary, we don't use corticosteroids upfront. We manage with antivirals, and we closely watch for secondary bacterial worsening, and we add antibiotics if there is in all severe influenza, we start empirical antimicrobial therapy, antibacterial therapy. But if we find that there is a sequential multi-organ failure with hepatobiliary dysfunction as well as with DAC, which is going to set in, then we start with IVIG. We don't go with steroids upfront. We give IVIG, and then steroid is in a systemic influenza we don't use unless we find an evidence of hemophagocytosis, which we get at a bone marrow.
Another question, like as per most intensive care protocols, if you have ARDS, then they would give steroids as management of ARDS. So would that apply to your patients with influenza as well? You would anyway give steroids, all ARDS?
We don't use steroids for all ARDS. We use steroids for ARDS, which we are on conventional ventilation on maximum support. And it is in the early phase of ARDS, not in the late phase of ARDS that we are receiving. And severe ARDS, the oxygenation index is high. We do, and there are elevation of inflammatory markers like CRP, procal, and ferritin. We use ferritin is not in this phase, CRP, which is very high. So in these cases, when we find the oxygenation index is high, we find that the patient there is a difficulty in ventilating the child. We use the Meduri regimen of giving steroids, which is the 2 mg per kg per day dose as a prolonged infusion over 24 hours daily.
Okay, so you would still be hesitant in using steroids upfront in your patients with influenza,
Yes.
pneumonia.
Yes.
Yeah, because there is also a higher incidence of infections in influenza. early on in illness, unlike COVID, because in COVID, you generally see the bacterial and fungal infections coming later on in the illness. But in
Yes.
influenza, even day 5, day 7, you can have aspergillus, you can have pneumococcus and MRSA.
So it's a
So
co-infection that is a killer in influenza, rather than that is what is the previous pandemic data shows, more than the cytokine storm, which is a killer in influenza. It is a co-infection with bacteria. So our window to use immunomodulation in influenza is too short if we have to do a trial on that, unlike COVID, as you said, pointed out very specifically.
And one more question, though not direct.
Sorry, we are just running a bit late, and I think Dr. Scott
Okay,
Khanna
sure.
has to leave in another
Okay,
20-25 minutes. So Dr. Karthik, there are a few questions in the Q&A box. If you could just answer those questions, that would be great. And I now request Dr. Satish Kumar to kindly introduce our experts for the next session, which is the case discussion. Thank you.
Yeah, good evening, friends. So far, thank you, Rainbow team, for inviting us to moderate this session. So next session is going to be very interesting. So far, we heard about various viral infections and cytokine storm. So now then the next session of case discussion, we'll be having interesting cases, the real life cases. This session will be moderated by Dr. Rakshay from Rainbow Hospital. And we already heard Dr. Scott Khanna, who is Assistant Professor of Pediatrics from University of Pennsylvania. And he is also the attending physician of Pediatric Rheumatology and Immune Dysregulation from Children's Hospital of Philadelphia. And the second expert will be Dr. Suchitra Ranjit. She is a senior consultant and head pediatric ICU in Apollo Children's Hospital, Chennai. Over to you, Rakshay.
Thank you, Dr. Satish, for a kind introduction. So Dr. Pavitra Vishwanathan is one of our fellows. She is doing her 2-year training and is almost completing her fellowship. So she will be presenting one of the difficult, challenging cases we had last year. As we go through this case, we'll generate a lot of discussion points. And like what we saw in a lot of Q&A, there are a lot of practical issues, challenges which many of us face. And like everyone is mentioning, we are in middle of a viral epidemic of late, with lots of viruses creating havoc across the country. And we thought it would be prudent to discuss one of the viral sepsis case and take inputs from the experts to see how we can optimize outcome of these children. So with this, I would request Pavitra to start her case. And during this case, when she presents, we're going to stop in between and bring up relevant discussions with regards to case management.
Hi, everybody. Thank you for the opportunity to present in the second cytokine release syndrome conference. So this is about patient T. She was an 11-month-old female child. Background was normal. She had no previous admissions and she was thriving well, and she was vaccinated up to date. And she presented with this course to our hospital. She started out with a low-grade fever and cough cold, which lasted for 3 days and started becoming a high-grade fever by day 4 of illness, which prompted the parents to visit the local pediatrician and was advised paracetamol. And they noticed that she started vomiting by day 5. And at the end of day 5, she started becoming drowsy. And on day 6, things were not going okay for her. She started having increased work of breathing. She was not very active even in the interfebrile period, and the feed was reduced. On further probing, we also noticed that she had actually double dosed on every paracetamol that was given to her, which was given approximately every 6 hours in a day. And the cumulative dose over the 72 hours was coming to 390 mg per kg. She got to us on day 8 of illness, and in our ER, she was noticed to be drowsy and tachypnic. Her RR was 65 to 70 with subcostal, intercostal retractions and nasal flaring. She had occasional grunt and saturations were 88% in room air. Chest had bilateral crepitations. Hemodynamically, she was okay. She was tachycardic. She was drowsy but responding to pain with a GCS of 12/15, and she was afebrile at admission. The last paracetamol was given 6 hours prior to reaching our ER. So she had basically a respiratory distress and a neurological dysfunction. These were our major issues at admission. And the primary labs, as you can see, shows a leukopenia of 3,900 with 15% neutrophils and 80% lymphocytes. Platelet count was 2.3 lakhs. CRP was raised. ESR was 22. Urea creats were okay. SGOT-PTs were elevated. OT was 1225 and SGPT was 942. Bilirubin was 0.9. Ferritin was also raised. It was 1517 nanogram per ml. She was dengue negative and COVID IgG positive, and the X-ray at admission shows bilateral infiltrates, right more than left. She was initiated on HFNC 40% FiO2 with 15 liters per minute flow, and she was given symptomatic care, and antibiotic ceftriaxone linezolid was added pending cultures.
Yeah, I think at this point, I think to both Dr. Scott Ken and Dr. Sujita Ranjit, would you consider that this child currently is in cytokine storm? And how do you actually interpret these investigations, especially considering that child has bit overdosed on paracetamol too? And also we want to know, apart from providing the supportive care and antimicrobials, would you consider immunomodulation at this point in time? And if yes, which one?
Could you just go back to the previous labs, Pavitra?
Yes, ma'am.
Thank you.
Can you, I'm so sorry. The platelet count in lax is a bit foreign to me. I assume that's a normal level?
It's normal, yes.
Okay.
Anything more than 1.5 lakhs is a normal count.
Is the child in cytokine storm? It's a tough question. I think it's important to not think of any of these things as binary, but that they're all graded. And so certainly the child has some inflammation. It's unclear whether the COVID IgG is positive because the patient has seen the virus distantly, or this is an acute COVID infection, but it certainly could be. But there's nothing here that jumps out to me that this is a child that acutely needs immunotherapy. There's no evidence of DIC. You have a bit of transaminitis, but potentially you have a good reason for that. You do have the ferritin bumped fairly substantially. Hepatitis can drive ferritin release, not usually toxic hepatitis, but if there's any interaction between the Tylenol and the viral infection. But I guess it's reassuring to see that the bilirubin's not elevated. So to me, that suggests maybe this is more toxic. So I don't know, without the child in front of me, I don't feel incredibly strongly about starting steroids or something else, because I don't know that the parameters that I'm staring at are things that we would expect to get dramatically better with steroids or anakin or anything we might use in this kind of situation.
Yeah, Dr. Suchitra, any comments on the labs? So just CRP less than 6 is the normal cutoff. Can you go back to the labs, Pavitra? Yeah, so I think just it might be that the values some of them might be confusing. So what's abnormal here is the total count is 3,900. The neutrophil count is just 15%. The CRP cutoff was 6. It has gone up to 51. Ferritin is elevated. LDH is elevated. SGOT, SGPT, the normal cutoff is around 50. It has gone to 1,225 and SGPT is 942.
Yeah, thank you. This is my first session, so thanks for the invite, and it's wonderful to be part of this. So as an ICU physician, I would think this is COVID with some superadded bacterial, and the paracetamol is contributing. And I would really see the response to supportive treatment. I would give the antibiotics and the high flow, hydrate him well, and look at the trends in these numbers. I agree with that there's no compelling reason to give immunomodulation right at this point in time.
Thank you, Sujit.
Doctor, I think we need to highlight, Dr. Ranjit said something very important about the trends. If the LDH was jumping up, or the ferritin was, 200 yesterday and is 1,500 today, that might actually sort of compel me to say, well, we might want to think about that. as opposed to if this is just kind of where the patient has been for the last 24, 48 hours. So, monitoring, I think, becomes fairly important so you can get a sense of what the trajectory of this patient is. I think Dr. Ranjit's right on there.
Yeah. So I think if I were to summarize your comments, it sounds like there is some amount of hyperinflammation, but probably it does not probably warrant immunomodulation as of now. We need to see the trend values and how the child evolves from now to decide about how we go. And as of now, antimicrobial supportive therapy is the best way to go ahead, right? So yeah, go ahead, Pavitra.
Okay, sir. So this is how the evolution was in the first 24 hours since admission. As we discussed, we also considered this as a viral pneumonia with possible secondary bacterial infection, and the transaminitis was possibly being contributed by the paracetamol. So we started out with HFNC, but there was progressive increase in work of breathing, which warranted a mechanical ventilation. The initial blood gases showed metabolic acidosis with lactates of 1.9. The respiratory support was 40% FiO2 with 21 and 8 pressures with 30 RR. Saturations were okay, ETCO2s were okay. There was persistent tachycardia, and this tachycardia was reaching up to 220 per minute, and there was disproportionality in the heart rate compared to the temperature. And the child started running temperatures from 11 p.m. at night. The child was admitted at 1 p.m. And this high-grade temperature of nearly 104 lasted for around 5 hours. And she also started having a hemodynamic instability, requiring upping of vasopressors up till 0.2 mics per kg per minute of both adrenaline and noradrenaline. Bedside POCUS showed RA-RV dilatation with moderate to severe PAH, with interventricular septum being in midline, and sildenafil was initiated. We started NAC infusion as per paracetamol overdosage protocol, and for the metabolic acidosis, isotonic chloride-free fluid were continued. And we continued the same antibiotics pending cultures, and the respiratory panel report was awaited at this point in time. So we started out the next day with the following issues. Clinically, we had respiratory failure on mechanical ventilation, hemodynamic instability, which had worsened overnight with hypertension. Was
Yeah, I would request everyone to just mute their mics. Go ahead, Pavitra.
So our respiratory panel did not show a COVID positivity. However, we had respiratory syncytial virus and streptococcus pneumonia, which was picked up. The X-ray had worsened. It shows bilateral infiltrates. And we started out with these labs. We had a stable hemoglobin. However, the total counts had dropped to 2,900 with neutrophil lymphocyte of 24% and 74%. On the brackets, you have the absolute counts. There was a drop in platelets. OTPTs were better on day 2 with stable bilirubins and a drop in albumin. CRP had reduced from 51 to 4. And ultrasound abdomen showed altered liver texture. Apart from that, lungs wise, it was bilateral collapse consolidation with bilateral minimal pleural effusion. So lab wise, the issues we started out were leukopenia with slight drop in platelets. CRP was improving at this point and transaminitis was better.
Yeah, so this is how the things evolved over next 48 hours, 24 to 48 hours. It appears that the liver function tests and the inflammatory markers were actually coming down, but the blood count, those is showing worsening leukopenia and the dropping platelet count. So is that a concern, and what would we do at this moment? I mean, with these kind of lab situation, the clinically child seems to have worsened, land up getting intubated, needing a bit of ventilator support, has a bit of pulmonary hypertension.
Dr. Kenna, would you like to go first?
No, by all means, you're the intensivist.
Okay. All right. So, yeah, I think Raksha's summarized that clinically the respiratory status are worse and he's intubated. There's hemodynamic instability. I just had, just a side comment on the antibiotics, which was ceftriaxone and linezolid. Although you have got strep pneumoniae on the respiratory panel, one of the bacteria which does the maximum, this kind of, the rapid progression, I would really want to cover invasive staph, and linezolid is good for just the lung, is great for the lung, but not so good when there's hemodynamic instability and worsening lung. So to me, it really looks as if this child has a coexisting MRSA, which is quite par for the course for any kind of pneumonia, which causes rapid, both respiratory and hemodynamic worsening. So in a matter of hours, it can do it. The X-ray taken even 12 hours apart can show changes. So that's my only comment. I would be reluctant to consider this worsening due to hyperinflammation when your markers are actually better and the liver function is better. Certainly the white cell count and low platelets are a concern, but to me, I would consider this, as a first step, address appropriate antibiotic cover.
I would somewhat agree with that. I tend to think of these patients, and again, I'm a rheumatologist, not an intensivist, so you should always take what we say with a grain of salt. But rather than trying to lump any particular patient into, is this MAS versus TAMOF versus immunoparalysis, rather to think of each of these parameters as sort of individual physiologic processes that can vary, almost like the old graphic equalizers people used to have on the stereos, with one thing higher and another thing lower. So I agree, this patient's CRP improving should be indicative of a decrease in systemic inflammation at the time. The drop in platelets is concerning, could be consistent with an increase in DIC, could be consistent with some splenomegaly if the patient's spleen has gotten big for any reason, it's being trapped, and could also be indicative of something like thrombotic microangiopathy, which, not so much the TTP side of that, but more the HUS is certainly seen as a complication of severe strep pneumoniae. And so, I'd be looking out for signs of hemolysis, renal failure, or other sort of signs of TMA. Increasingly, places are able to send a biomarker of thrombotic microangiopathy, which is the soluble C5b through 9, which I think we're still just now learning how to use, but has been helpful in some of these kinds of patients. But schistocytes on peripheral smear may be just as helpful in a situation where you can't get that kind of a test.
Thank you. Thank you so much.
So this is how she evolved during the day 2 of admission, which is day 9 of illness. The mechanical ventilation parameters remained stable. However, she persisted to have this tachycardia, and there was disproportionality whenever there was a fever. We started out with IVIG, 1 gram per kg over 24 hours, and a low dose methylprednisolone because she had a clinical worsening. She had increased requirement for vasopressors. There was a drop in platelets and there was a drop in total counts. After starting IVIG, what we noticed was that we could taper and stop one of the vasopressors, and the second vasopressors we were able to reduce to 0.15 mics per kg per minute. We initiated diuresis at this point. She persisted to have fever, which is lasting for at least 2 to 4 hours, but the degree of fever seemed to have come down. But throughout the day, what we noticed was her temperature never touched baseline. It was always above 100, and the Tmax was 103.6. This point in time, we got our cultures back. The blood and ET cultures were negative so far. The urine culture showed E. coli positive, and we had changed our antibiotics according to sensitivity pattern, meropenem and amikacin. A stat dose of filgrastim was given. So the next day started out with these labs. We saw that there was a drop in hemoglobin, a drop in a platelet to 82,000. Total counts increased. This was post GCSF. It has increased to 9,570. And it was neutrophilic predominant, 81%, with 17% being lymphocytes. Bracket shows absolute counts. The SGOTPT seems to be getting better. The bilirubins have been stable. There was a drop in albumin, and urea creates are stable. And the CRP shows a raise. On day 2, we had seen that there was a drop to 4, and now it has raised to 29 again. So the clinical issues at this point in time that we started out was persistent tachycardia and persistent fever. Hemodynamics was better. Pulmonary hypertension is better. There was, however, a raised CRP. There was a drop in hemoglobin and platelet count. Transaminitis was improving, and ferritin, which was 1,500 on day 1, reduced to 1,246 on day 3. DIC workup was sent. It was negative. However, procalcitonin was more than 200 nanogram per ml. She persisted to have fever during this time, and her baseline remained above 100 and heart rates remained above 150. There was always a disproportionate tachycardia. Ventilator parameters were stable. We were actually able to wean off noradrenaline further. We reached till 0.05 mics per kg per minute. We restarted feeds and we escalated, which was tolerated. We stopped methylprednisolone because there was a culture positive UTI and the procalcitonin was more than 200. NAC infusion was stopped. We had completed IVIG at this point in time, and we continued the antibiotics. The blood culture and ET cultures have remained negative so far. The next day, what we see that is the ferritin is still downtrending. The CRP from 29 reduced till 20. And the CBC, if you see, the hemoglobin continues to drop and the platelet count continues to drop. The total counts are still rising. We had just given a stat dose day before yesterday, and we had not repeated it afterwards. And there was 88% neutrophils and 9% lymphocyte, absolute count being 1,566. The SGOTPTs are still getting better. Bilirubins are stable. Urea creatinine is slightly going up, 52 of urea and creat of 0.7.
Yeah, and I think one of the great challenges for us while managing this case was the persistent fever spikes, which was almost touching 103. And even when the child was afebrile, the heart rate were persistently high, 180 plus to 200. And one of the things we've noticed even in the dengue is that anyone having a persistent high fever, they seem to really have a poor outcomes. So I just wanted to know about, especially interpreting these values with regards to procalcitonin, because many of us use it to identify bacterial sepsis, and there are people who say it might not just be a marker of bacterial sepsis, but could be a marker of inflammation. Any thoughts on that?
So you're absolutely right about the procalcitonin, although I think in this case, it's telling you what it's intended to. But if you look in certain inflammatory diseases like MISC or what was called PIMS-TS, I believe in the UK, or in Kawasaki disease that's severe, the procalcitonin levels are every bit as high as bacterial infection. So it is not entirely specific for bacterial infection, but it is true that it's higher in certain kinds of inflammation than in others. And in this case, I think that possibly the positive urine culture and a child who has severe bacterial disease, potentially with areas that are not being reached by antibiotics in terms of, if she's got empyemas or abscesses in the lungs that have set up, plus that UTI, I'd be concerned with this change in her inflammatory markers from one that has some features of MAS with a high ferritin, a high LDH, to something that's a bit more bacterial looking, that this has shifted in that direction. With the drop in the platelets, you might consider something like anakinra if you're not sure what direction this patient is headed, even though the ferritin's dropping, just as something to do that in addition to sort of looking for the infection and broadening antibiotics.
Thank you, Scott. Any comments, Dr. Sujitra?
Yeah, agree. The first thought would be to look for occult infections and strep pyogenesis. Yeah, it's well known to cause anything from endocarditis to empyemas to even meningitis and abscesses. So having said that, there's a lovely meta-analysis and systematic review which showed in almost 2,000 patients that procalcitonin, an initial procalcitonin, it's almost like a flip of the coin. it was a sensitivity of 0.55%. So not only was it not very good at telling you there was a bacterial infection, a low value could not reassure you that the patient did, that a low value meant it did not even have a good negative predictive value. So if it's low, you can rule out bacterial infection. So I would really say that you need to look at the big picture and not too much of the numbers. Try and create the whole, what is going wrong. I'm not sure what the immunomodulation did in this child. Certainly improved, but what exactly were you treating? Was it the combination of appropriate antibiotics and support that you gave? Maybe his, the IVIG certainly would have helped, but could you say to this audience it was a cytokine release syndrome? I'm not quite sure. Yeah, Rakshay.
Yeah, thank you, Dr. Suchitra. Can you go to the next slide?
So on day 4 of admission, the current issues from the previous day were as follows: persistent tachycardia and fever. The CRPs were reducing and the drop in hemoglobin was still there. The platelet counts were okay. Transaminitis was improving and the ferritin had reduced. So we continued to have fever. There was persistent tachycardia. Ventilatory parameters were stable. We started noticing that there was a little bit of finger discoloration in the upper limbs especially, and Dopplers were showing monophasic flow. Low-dose adrenaline infusion was started and pentoxifillin was started. Feeds continued to be tolerated, and we noticed that the urine output started reducing for the child. And there was a persistent drop in lymphocyte count. Thrombocytopenia was present. So we thought, could it be a fungal infection? And if it was a fungal infection, the idea was to look for it and initiate appropriate treatment. So this was the finger discoloration that we noticed, and the arterial Dopplers are showing that there was a monophasic waveform in both radial and ulnar arteries in both limbs, and there was extensive subcutaneous edema. These were the CT chest findings. It showed bilateral areas of consolidation with a lot of air bronchograms and ground glassing, which was noticed more on the right side and then on the left side, and the possibility of infectious etiology to be considered. On day 5, what we noticed was that this child was having persistent tachycardia. Finger discoloration was present from the before day, but it was non-progressive. There was oliguria and there was rising renal parameters. As we can see, the urea has jumped from 52 to 84 and creatinine from 0.7 to 1. CRP continued to be reducing from 20 to 7. There was a drop in hemoglobin from 7.9 to 7.7, and the platelet counts was showing 1 lakh. This was spontaneous. We had not transfused the child. The total counts was still in the rising trend. It was 20,000 with 87% neutrophils and 10% being lymphocytes, 2,050 being the absolute lymphocyte count. This was the blood gas. From day 4 to 5, we can see that the pH has slightly dropped from 7.36 to 7.27, and the bicarbonates were 16, and the lactates were more or less stable, 1.6 to 1.4. So on this day, we noticed that the fever was persistent, but the tachycardia was more compared to the last 24 hours. The ventilatory parameters were okay, and there was transient hemodynamic instability midday, which required both noradrenaline and adrenaline support of up to 0.3 mics per kg per minute. We transfused the child with PRBC 15 ml per kilo over 3 hours, after which we were able to taper off noradrenaline and adrenaline to the lowest dose of 0.05 mics per kg per minute. For the evolving AKI, we restricted fluids and gave a conservative management. But through the day, what we noticed was there was persistent drop in urine output, and there was anuria for the last 4 to 6 hours. The discoloration in the hands remained static and non-progressive, and the Dopplers continued to remain the same.
Yeah, so I think the issue was that the child was persistently becoming febrile. The repeated cultures and none of them came positive. and the child seems to be developing this kind of microangiopathy features. And do you think the child is developing something like a thrombocytopenia associated multi-organ failure? And does it warrant a plasmapheresis? Might be I can ask Dr. Randy Crown and then Dr. Suchitra.
Were there schistocytes on the smear?
No, sir.
Yeah. And with the platelet count going up, that would be unusual. Having said that, you can certainly, unfortunately, even if this is a cytokine storm of sorts, get thrombotic microangiopathy on top of that. My overall worry, a little bit different from Dr. Khanna in the beginning, is that there's some form of cytokine storm occurring no matter what the infection or infections are. And my personal bias, because I just am comfortable with it, and we know that outcomes are better the sooner you start it, would have been to start IL-1 blockade. And this child did get, it looks like, at least a day or two of steroids. It may have turned a few things around temporarily. But by the time, if this is a cytokine storm, by the time the kidneys are involved in most of these processes, it's not typically a major aspect of most cytokine storms. It's usually kind of the body's starting to give up. And the darkening of the distal digits I've seen, for example, in horrible cases of influenza cytokine storm, where you can even lose digits. So, you know, it's concerning that it looks like things are starting to shut down kind of more globally.
Yeah. Dr. Suchitra?
Yes, I'm not convinced there's all features of thrombotic microangiopathy, but I agree in this child that it might be worth considering plasmapheresis, because there are reports that many childhood, especially in infants, many childhood infections, viruses, and bacterial can set off this thrombotic microangiopathy. So I agree with plasmapheresis, although it is a little strange. There's not many fragments in the smear, and yeah, the platelets seem to be quite stable.
Go ahead, Pavitra.
So on day 6, the labs that we see are worsening. You see that the SGOT-PTs are becoming worse. It has jumped significantly, 80 of OT on day 4 to day 6, which is showing 1,700 units per liter. SGPT from 146 has gone up to 420. Bilirubins are rising. Albumin more or less is okay. Hemoglobin 12.2 is after a transfusion on day 5. Total counts seem to be rising, and platelet counts again seem to be dropping. I'm sorry, this is 1 lakh. Urea seems to be coming down. Creat is more or less the same. CRP continues to be stable. So on this day, we started out with these issues. The ever-persistent tachycardia and fever with static finger discoloration and anuria at this point. There was worsening transaminitis. There was persistent metabolic acidosis, and the lactates has started rising for the first time since admission. So the pH has dropped to 7.2. Bicarbonates are 14. This is despite being on isotonic chloride-free fluid. And the lactates have gone up till 4.7. So this day, there was persistent tachycardia up to 180 per minute. Ventilation, however, was stable, but the vasopressor requirement has started going up again, with maximum support of adrenaline reaching till 0.3 mics per kg per minute and noradrenaline 0.2 mics per kg per minute. There was no response to an albumin bolus. There was persistent metabolic acidosis with anuria, which was requiring a sled and a scuff. We restarted NAC infusion because there was worsening transaminitis and vitamin K daily dosing was started. Since the overall clinical picture had worsened, we restarted methylprednisolone, and anakinra was reinitiated at this point in time with 2 mg per kg per dose, 12th hourly. We repeated the cultures, and meropenem poly B and liposomal amphotericin B was given. There was new onset purpura in lower limb, which was rapidly progressive, noticed since midday. And we wasted no time. We gave 1 session of double volume plasma exchange. She also started having melena, which was large quantity. So we stopped feeds for the moment and continued just IV fluids. On day 7 of admission and day 14 of illness, this was postplex. The labs continued to worsen. There was a drop in hemoglobin to 9. Total counts were still rising to 35,000. and the platelet count had dropped to 41,000. The ferritin has significantly jumped to 18,000 from 826, which was 48 hours back. SGOT-PTs are continuing to worsen. 5,700 was the SGOT and 665 was SGPT. Bilirubin has increased to 2.9. Urea and creates were stable, and CRP continued to be downtrending at this point. So apart from the persistent tachycardia, which was there till the day before, we had a worsening in hemodynamic status. We gave a plex session because of significant clinical worsening, and there was progressive metabolic acidosis with rising lactates. And on this day, it had gone up till 12.9 of lactate with pH dropped to 7.1, and the metabolic acidosis was persistent. We also had hepatobiliary dysfunction and significant rise in ferritin. The cultures which were traced continued to be negative. This was the third culture so far for the child, and it continued to be negative. And the cultures were sent from blood, urine, as well as the endotracheal tube. And she persisted to be hypotensive. She had no response to albumin boluses. She persisted to have metabolic acidosis and rising lactates. She had altered GI aspirates, and ultrasound at this point showed no recordable blood flows to liver, kidney, or gut. And there was reversal of flows to brain. There was life-threatening hyperkalemia with wide complex tachycardia, which resolved transiently after medical management and emergency hemodialysis. We had initiated anakinra at this point in time at 10 mg per kg per day over a 24 hour as continuous infusion, because things do not seem to be going well for this child. However, despite all these measures, there was recurrence of arrhythmias and we couldn't be revived. And the follow-up cultures remained stable for this child.
Yeah, so I think it was extremely difficult for us because the signals in terms of the inflammatory markers were all over the place. At some moment, it was showing improvement. It did not really match with the clinical situation. Child was persistently tachycardic and had a very rapidly progressive course in the last 24 to 48 hours. So, I mean, I just wanted to throw an open question probably to Randy Crown, Dr. Ramanan, and Dr. Suchitra. I mean, is there anything else you could have done differently in terms of the management and even the immunomodulation?
I mean, I know I'm at the one extreme of this, and for a long time I butted head with our intensivists, but I think we've come closer to closer on how to manage children like this. For me personally, once I even kind of get a cytokine storm syndrome gestalt on my radar, I recommend anakinra. Not that it's going to fix things, but you know within 48 hours if it's helping or not helping. If it's not helping, you rethink or re-strategize, but at least you give yourself a chance, because we do have at least retrospective data that the earlier you start that particular drug, the better your outcomes. By the time they get to the renal failure part, and it's very hard to turn things around. I've occasionally seen megadose steroids turn things around at that setting, but not anakinra. But anyway, I tend to start it as early as people will let me, because I don't see a lot of downside to that particular drug, although I understand the expense worldwide. And I also tend to start at 10 mg per kilo per day and back off. I'd much rather do that than chase my tail the other direction, because we know of the safety profile. But that's just me. That would be the primary difference of how I would have initiated therapy.
Dr. Ramanan, any comments?
Yeah, I think you did everything. I might be on the same path as Randy, but probably a few miles behind him in my zeal to start anakinra. And given the settings you work in and the importance of considering infections, I don't think you could have done anything different. I think you initiated the right things at the right time. So no, I can't add much more to say you could have done anything different. Sorry.
Dr. Suchitra, any comments? You could have done things differently then?
Yeah, so what an amazing case, just a wild roller coaster ride going up and down. Initially seemed to show some signals for improvement. So, but it's interesting. I'm not going to comment too much on the immunomodulation because our two previous speakers have done that. But it's just an aside that if you see rapidly rising lactates out of proportion, and I'd really think about gut ischemia, areas of gut gangrene. And sometimes it's a source control that's required. We need to remember that even cell death and reperfusion injury, all of those can cause elevated ferritin. So it's not solely a pure inflammatory marker. It's got many, many sources. So, but a high lactate, rapidly rising lactate, and that Melina was no surprise. I think there's dead gut there, and dead gut causes intense inflammation. So unless there's no amount of immunomodulation going to work, unless, so I understand that getting a CT, ideally you need a CT with contrast. That's going to be challenging. Sometimes we convince our surgeon to just open, if it's very sick, and at least resect out the dead gut. I really believe we had a case just 3 days ago where large segment of dead gut, and that I was just thinking about it when you have persistent tachycardia, persistent markers. So it's just, I know inflammation is a big deal, but I just like to, think of keep like keep all avenues open. We shouldn't get too much blindsided by the numbers.
I think this is an extremely important point. And I think one of the important points also with regards to inflammation is a source control, just the way we talk about infection. Because if there's a continuous source for ongoing inflammation, unless you sort that out, no matter any immunomodulation might not help. That's a point which is very well taken. And probably what happened in last 24-48 hours, like what you just mentioned, the child seemed to have developed thrombotic complications everywhere. The skin manifestations were there, kidney had completely shut down. Probably like you just mentioned, child developed gut ischemia, melena, and probably perforation or probably a gangrene. And the difficult part was that the progression involved multiple organs, which happened quite rapidly. And though we started Plex, like you just mentioned, possibly there was a window where we could have probably looked for probably gut decreased perfusion or a perforation, considering that there was a persistent tachycardia. And it appeared like the hemoglobin was dropping disproportionately compared to the platelet count, and probably there was a thrombotic angiopathy process which is going on, causing gut ischemia too. So that point I think is a very important to make. And I like what you mentioned is I think the whole purpose of this whole meeting also has been that we should not just I think all the speakers have been pointing exactly the point you mentioned, that we always have to look for the source. Always, whatever we see in terms of the lab parameters, it tells us about the disturbed milieu, inflammatory milieu, and looking for the source apart from the control holds equally important. So I think that's a good point. Thank you so much, Pavitra, for presenting the case. And if there are any final comments, I would take those final comments and we'll wind this case up.
I think there are questions in the chat box as well regarding the case. So if we could just take those before we end the session.
Yeah, I think Dr. Suchitra wanted to comment something. We'll take that and then.
No. I was just going to say that great work, Pavitra, lovely slides.
And I think the great difficulty for us was the CRP being just completely all over the place, and in the end almost becoming a kind of a normal. And I think with the progressive liver dysfunction, CRP does become kind of unreliable marker too. And I think Dr. Mahesh Mohite has a question right from the beginning. His CRP was always low or normal. How do you explain severe CRS? Was it uncontrolled sepsis, superimposed, or immunosuppression? And I think the possibly the progression of the liver failure, I think was an issue. And oftentimes in majority of the viral infections, we don't see a CRP response. The ferritin is probably a CRP marker of bacterial sepsis. So that can happen. And yeah, and I think the similar question by Dr. Madhu to how did the monitoring CRP help? How reliable is it in the presence of liver disease? And I think like last few speakers also have spoken that CRP might not be a very reliable marker in the presence of significant liver dysfunction. And also in the viral sepsis, we might not see that degree of CRP elevation. Probably ferritin is a more reliable marker in looking at the severity of viral sepsis. So any more comments by Dr. Ramanan or Randy Crown, and we'll just wind up the session.
I'd only be repeating myself, just that, by the late stage, I agree that the gut was probably what ultimately led to the child's demise, but the sooner you get things under control, the better. I'm not saying it would have changed anything for this particular child, but it's just my particular approach to these things because people get infected a lot, including infants, but they don't all get this sick. And this kid was persistently sick and getting sicker despite what the labs showed. And so that gets the hair on the back of my neck up. And so if there's anything we can do to help that child beyond the stuff that the intensivists do, which keep these people and these children alive, then I would try to do it, particularly if it's a relatively safe intervention.
I think it's also a very important point what Randy Cron wants to bring up is that in a way, the end game is losing gut, losing kidney is just too late for immunomodulation. The whole purpose of starting this therapy is you don't land up in that situation, because once you land up losing organs, no matter what immunomodulation you do, might not actually give us a benefit. So trying this therapy is early in illness, and there's probably a sweet spot which we need to recognize at the bedside, and probably give a much more targeted immunomodulation if possible, with the idea that you prevent the progression of the illness to such severity. Yeah, thank you very much, Randy Cron. Any comments from Dr. Ramanan?
I don't think he's online anymore.
All right. Yeah, over to you, Dr. Chandrika.
Yeah. So thank you, chairpersons, for chairing this session wonderfully, and to the great speakers as well. I think with this we'll wrap up the second day of the conference, and we look forward to having you all participate in the conference again tomorrow. And we look forward to you all being equally active as you were on day one and today as well. So good night and see you all tomorrow. Thank you.